The reason we did this study is previous work from Framingham in a general population has demonstrated that having a low HDL, in addition to all the other risks associated with that, was associated with a higher risk of incident heart failure, developing new heart failure in a general population. That combined with the fact that when you think about what HDL in theory does in the bloodstream in terms of acting as a scavenger to reduce inflammation and the development of both atherosclerosis and arteriosclerosis, the question then remains, well, maybe this could explain part of the missing risk profile in these patients who go on to develop heart failure, despite the fact that we are reducing their MI burden, we're reducing their blood pressure, we're regressing their hypertrophy with aggressive antihypertensive treatment. So the LIFE study, which was designed to compare two different randomized hypertension treatments, is an ideal platform to look at this because we had very well verified outcomes and the ability to track HDL over time, just not at baseline. Because the other thing is when people think about risk factors, we tend to do these very simple analyses where we measure something at baseline and then we see what happens 4 or 5 years later, but are not taking into effect that these are changing with changes in clinical status as well as with therapies that are occurring over time. And so we looked at that and decided to look at how is HDL and its evolution over time going to be, is it predictive of new heart failure in this population? And what we found was a very, very, very strong association here, where the lowest quartile of HDL, when looked at whether you are in that group at baseline or go into that group over time, is associated with an adjusted twofold higher risk of developing new heart failure over average just under 5-year follow-up. Importantly, that adjusts for all standard types of risk factors such as age, sex, your history of previous MI, history of ischemic heart disease. We excluded patients who had a history of heart failure. It adjusts for your baseline and in treatment change in systolic blood pressure and diastolic blood pressure during treatment. We adjusted for the other risk factors that we've shown in this population for new heart failure, which includes regression of LVH on the electrocardiogram, as well as changing heart rate over time. And importantly, we adjusted for whether these people had incident myocardial infarction during the course of therapy, because obviously people who develop a new myocardial infarction might be considered more likely to go into heart failure. The other thing that's important is we adjusted when we had data on statin therapy and whether patients were on statins. And over the course of the study, gradually increasing number of patients were put on statin therapy, but this outcome is independent of the statin use. So we take into account their statin use, and HDL remains a powerful predictor of incident heart failure in this population. So having a low HDL is a very bad marker. As we were discussing before we started filming, the question of now what to do about that, I think we'll have to wait and see about the HDL raising studies. But in the meantime, I think what this does is it clearly points out that if you have a patient who falls into this group of very low HDLs, or if they go into that group, this is a very, very high risk population, not just for heart failure, but for other things, for incident diabetes and a variety of other problems. And these are people that probably deserve much more careful attention from their physicians and really careful scrutiny of all of their risk factors to see that we're managing them as best as we can.